Well, in the interest of time, we're going to go ahead and get started. There's going to be people joining us as we go, but we'll get started. So good evening. My name is Jay Phifer, and I'm one of the molecular sales consultants with Myriad Neuroscience in the Atlanta area. Outside of that, I'm a husband of 23 years, a son of Black parents, husband of a Black wife, and a father of 3 Black children. The question that people are going to ask is, why do I point that out? This has been a very challenging year for not only me, but a lot of us. But the problem is we've been trying to come up with answers to questions from not only my community, but my kids and my family that I frankly just don't have. The discussion that you're going to be a part of tonight is not just to look into my personal experiences, but these are the experiences of many families that look like mine. And to be fair, many families that don't look like mine. So thank you very much for coming out tonight. I know we have all had a long day and we'll be respectful of your time with this very engaging conversation. If you have any questions for the panelists, please submit them via the chat feature and we'll get to them. We'll get to as many as possible. Any questions that aren't answered during the presentation tonight, we'll do our best to follow up with answers from the appropriate panelists or even the charming moderator as soon as possible. Real quick, did I mention that I'm that charming moderator? Okay, just checking. So buckle up. We have about an hour and 15 minutes to get into some pretty deep conversation. Some of the conversation may be a bit uncomfortable, but change is often uncomfortable. Our goal is that these conversations and thoughts continue not only into your homes tonight, but into your workplaces tomorrow and in the future. There will be some topics that we just don't have the answer to, but the conversation will lead us in the right direction. So welcome to tonight's presentation titled Inherited Mistrust, What's Behind Black Skepticism of Mental Health Care? Our conversation will center on what's happened in our nation's past to cause the deep-rooted mistrust of the mental health system and of clinical trials related to the genetics in the Black community. This mistrust carries over into all realms of healthcare, from HIV and AIDS to the current COVID-19 vaccine and pandemic, but those topics we're going to approach on a different day. Mistrust damages the clinician-patient relationship, discourages patients from getting the care that they need, and prevents clinicians from fully understanding context about a patient's experience that could lead to more beneficial treatment. This webinar will equip clinicians with knowledge and information around difficult questions like, what are the historical causes of mistrust in the Black community? Is anyone in the medical community working to break down barriers of mistrust today, and how? And how should clinicians approach patients who are skeptical of care? We will use those points to guide our conversation with our incredible group of panelists. I am so honored to introduce them to you now. First, we have Dr. Malaika Berkeley. She's the co-founder of Global Health Psychiatry in Atlanta and a co-author of MindMatters, a resource guide to psychiatry for Black communities, and released just this month, Bree's Journey to Joy, a story about childhood grief and depression. We also have Dr. Lonna Mollison, who is a medical science liaison with my team here at Myriad Neuroscience. She has an extensive history as a researcher with a particular passion for bringing genetic screening into the medicine mainstream so that all people benefit. We have Dr. Iverson Bell. He is an associate professor and the residency training director of psychiatry at the University of Tennessee Health Science Center, and Dr. Balin Durr. She is a child, adolescent, and adult psychiatrist at the Will County Community Health Center in Joliet, Illinois. So first, I'd like to say thank you to our impressive panel for being with us. With your help, we'll have an incredible conversation around this difficult topic. We'll get started with the most well-known and most often referred to cause for mistrust, the Tuskegee study of untreated syphilis in the Negro male, which has been caused the most enduring wound in American health science. Tuskegee was a 40-year experiment run by the Public Health Service officials in Tuskegee, Alabama, that followed 600 rural Black men with syphilis over the course of their lives. The study, which began in 1932, didn't tell patients of their diagnosis and didn't even treat them. This experiment went on until 1972, by which time many of the men had died from complications of syphilis, and several of their wives and children contracted the disease. Tuskegee continues to be an important touch point, but is hardly the only example of why Black America does not trust the medical community. Harriet Washington, in her book Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present, says that mistrust of medical research and the healthcare infrastructure is extensive and persistent among African Americans, stemming from more than 4 centuries of a biomedical enterprise designed to exploit African Americans. So let's go ahead and get started. You guys have heard enough from me. Let's get started with a question for all of our panelists. Each of you have chosen careers related to the practice of mental health care, but has mistrust of the healthcare system been present in your families? or is it still present? And if yes, how did your family react when you first told them about working in mental health or working with genetics? We'll get started with you, Dr. Mollison, first.
Sure. Thank you for the question, and I'm so glad to be here tonight. So as you mentioned, my background is in genomics research, genomic medicine research. So my family, I'll never forget, I was at a family reunion and I was explaining my postdoctorate project, which was how to incorporate genomic screening into routine childcare. And my family members were so hesitant. They said, what are those white people going to do with my DNA? And it made me pause because I realized in that moment that my own passion and excitement and enthusiasm for precision medicine somewhat blinded me naively to the fact that reasons for mistrust would extend to this emerging field.
Thank you, Dr. Mollison. Dr. Durr, same question.
No, with my family, we didn't have those kinds of concerns. I think to be honest with you, many of them didn't really comment at all. And I think for those who did, some of their concerns was that now, because with my additional training and skill set, that they were going to get found out. So they're going to get exposed. So in that context, for some of them, it's are you analyzing me? But in terms of the genetic aspect, no one has expressed a concern. As a matter of fact, because my mother is actually the family historian, and so she's busy trying to connect us to ancestors. So then she's more open to it. My sister, my dad, they've all done genetic testing. I have, my son has. So we've been actually much more open to it.
That's great. That's great. Dr. Berkeley?
And so your question was, did we see any mistrust of the medical system as a whole within our families? And I would have to say that I might be coming from a slightly different perspective from most African Americans, because I'm actually from the Caribbean.
Wow, okay.
So it's a little bit different in that, no, I did not see any signs of mistrust of the medical community growing up. But I suspect that in large part that was because most of the providers looked like us. Most of the medical providers were Black, so I think that that may have mitigated any concerns about mistrust of the medical community. We didn't have a whole lot of resources growing up in the Caribbean, but I did not ever see any concerns about trusting medical providers. So my family was in fact very open to my going into medicine and very encouraging.
So with that being said, Dr. Berkeley, like we mentioned the Tuskegee experiment, and that's something that, most young Blacks in the United States hear about from a young age. So is that something, did that ever really reach the Caribbean, or were you guys just not really made aware of that?
No, that, and I'm not sure like at what point that comes into the conversation as an African American, like what age and what sort of conversation brings that topic up. But no, we were not aware. I don't remember any conversations about the Tuskegee experiment. The only time that I came to know it was when I was in medical school here in the US.
Okay, wow, very good. Dr. Bell, same question. Any historical issues with the family or questions from the family about you going into healthcare, especially mental health?
I have kind of an interesting background. My mother was a nurse, my grandmother was a nurse, I had an uncle that was a family practice doc, and my father was a veterinarian. My father was unhappy that I wasn't going into his branch of medicine, but generally the people around me were accepting of the field of medicine not so sure about psychiatry. More in a larger sphere, I don't think there were too many questions about going into psychiatry or medicine, but family background became kind of interesting in that my grandmother wouldn't tell us anything about her parents or any of her extended family. But from all the people that I've known, it's kind of surprising that I don't know anybody that's objected yet to genetic testing of the sort that's around commercially today.
Wow, that's very interesting. So we'll go right from that to Dr. Mollison. Could you elaborate on the historical factors behind this mistrust as it pertains to medical research, primarily genetics?
You already mentioned Tuskegee, but of course it predates that, and it's linked to the extensive and unfortunate racist history of this country, over 400 years of slavery. It was very much a common practice when the slaves could no longer function in the field, that they could be sold for medical experimentation. After slavery was abolished, that ushered in the Jim Crow era, which lasted 100 years. During that time, there was persistent and permanent, the hope was for permanent oppression of Black people, which meant that we did not have equal access to medical care and education. But also during that time period, the eugenics movement arose, which really taught that your genetics was responsible for your social status in life. And the goal was to eliminate the unfit people. And of course, it's not hard to imagine who that was. And so that resulted in forced sterilization, which there were laws created to support forced sterilization. And it wasn't until 1974 that Virginia was the last state to overturn their forced sterilization laws. And then that feeds into the Tuskegee syphilis study, as well as HeLa cells and the HeLa-Lax study, where medical facilities have often been supported and grown exponentially by the exploitation of Black individuals.
Wow, so it's a lot more extensive than just, we don't trust it because of Tuskegee. It builds upon that. That's interesting because, most people do not know that type of context or that type of historical relevance of that. Wow. Thank you for that, Dr. Mollison. Another question for all of our panelists. How do you help your Black patients overcome this mistrust? And is the level of mistrust higher than in your non-Black patients? And we'll go ahead and start with Dr. Durr.
So, that's an interesting question. I actually saw someone today, and there was a new patient, and the parent raised the question in terms of medication about the fact that they didn't want their child over medicated. And so those are that, along with, is it going to change, change me, change my personality? And people, I think, is very much feeling like they may lose control, or sometimes being concerned that they don't want to be a zombie, or they want their kids to be a zombie. And so, sometimes I use humor. So especially when it's around, Halloween, and people are saying, I don't want my kid to be a zombie. I was like, yeah, but I'm trying to get all the kids to be zombies. We're going into Halloween. So, to bring a little humor to it. And so I think that it's important to honor people's concerns. I think that one of the things that we try to do in general, and the studies show this, that medical providers attempt to provide care because we're trained to fix things, and we attempt to provide care too quickly, meaning before we've established relationship, before we establish rapport. Sometimes the patients don't agree with us about the diagnosis, they don't agree about the treatment. They're depending on what the diagnosis is, they lose it's whatever dreams and hopes that they had, either for themselves or their children or other family members. Now that can be lost if it's a chronic severe mental illness. So it's one of the things I think that is important, and I don't have the answer if it's more prevalent among African Americans or Hispanic people or other people of color. I think that just in general, of course, because of the socioeconomic and political climate that we have lived in for hundreds of years, it certainly can add to it. But I think people have legitimate concerns. And so I think the thing to do is to honor their concerns and to work to form relationship and rapport. And then that way you develop trust. And in that way, I'm able to actually help. But without that, I can't help people against their will.
Very good. So you got to get them to trust you so you can help them. Very, very interesting. So Dr. Durr, building on that, how do you think stigma and the long history of stigma is involved in this mistrust?
It's huge because the average person confuses identity with what I call performance or results. So they'll think that because I did this, that there is no redemption, right? So they're constantly beating up on themselves, which is an issue. And then they also, the thing that I don't think that people really fully recognize why the stigma is so huge is because one of the things that's actually wired into us is actually connection, right? Food, water, sex, i.e. reproduction, and social connection. That's hardwired into us. Why? Because those things promote survival. So the problem with having anything that seems to make you odd, strange, weird, not part of the herd, not part of the tribe, is that can actually not only make you vulnerable, but put you at risk of being harmed or being killed. So for people to look at you in that way, that you have some mental illness, and of course we see people again, sometimes you see the lady with the shopping carts or the man with the shopping cart that's disheveled and, not clean and those kinds of things. So people have real fears and real concerns, both for their future, because everybody wants fulfillment and happiness. So they have real concerns about their future, but they also have real concerns about their safety in terms of the stigma of mental illness. And so they also don't recognize, and one of the ways I try to help people understand this is, if you break your leg or somebody else breaks your leg, then the other person, if they broke it, they're responsible for breaking it, but you're responsible for healing it. And if you don't know how to fix your car, you don't usually just abandon it on the road and never go back to get it. You find a mechanic to fix it. So in the same way with mental illness, it's a set of tools and it's a skill set and it's training. So if you don't know how to do that for yourself, then get some help from somebody who does have that ability to help you heal yourself, the same way you would if it was an electrician or, again, an auto mechanic or just whatever other things that you don't know how to do, but you got to seek help from a professional or somebody that knows what they're doing.
Very good. Dr. Berkeley, I know that you have, we've talked in the past and you had a lot to say about the stigma of mental health. What are your thoughts on this?
I think Dr. Durr raised some excellent points in terms of, connecting with African-American patients. I think that, the first step is to acknowledge their concerns and acknowledge the validity of their concerns. Because what we don't want to do is to make people feel like they are incorrect in having concerns about practitioners and the history of medicine. And then what also Dr. Durr mentioned is that what she described is that she educates patients, right? She educates them about taking a similar scenario. If your car breaks down, you don't just abandon it, you go to a professional to get it fixed or to help get it fixed. So these are things that are actually very important in stigma, in addressing the stigma within the community. Now, There is generally a stigma surrounding mental health, not just in the African American community, just in general in the community, but it is greater in the African American community. And so these steps are things that are important in addressing the stigma. You have to acknowledge their concern, acknowledge the validity of their concern, and then, provide whatever education you can to help them better understand the conditions. One of the things that happens, I think, is that in the African American community, we have been, through media sources and other venues, we have been led to believe that bad behavior is a part of being Black. We see most of the times criminals on TV are Black or whatever, that has historically been the case. So then when we see behaviors that are not, say, normal, we just accept that as, they're just being bad, because that's what we were taught, is that, we are just, we're bad people. So in our book, MindMatters, what we attempted to do is to educate the public about behaviors that you might think you may just, put it down to somebody being bad, somebody being promiscuous, but perhaps that is a symptom of something else. Perhaps somebody's promiscuity is a symptom of being bipolar, or somebody's promiscuity is a sign that they may have been abused in some way. So education is very key in addressing stigma.
Very good. And Dr. Berkeley,
Jay, if I could, because I'm sorry, I forgot a point that I think is really important. One of the things too, in helping people kind of separate from the stigma, is to helping them understand that, again, that who they are is not their brain. So, and especially if people come from, a spiritual or religious or wisdom tradition that says that, you come from the Creator, then the way I laid out to people of science, I'll say to them that you're in the universe and the universe is in you, that the atoms in your body comes from exploding stars, the calcium in your bones comes from exploding stars, the iron in your blood comes from exploding stars. So how can you, a child of the universe made of stardust, be inadequate? You and yourself are not inadequate, but you're having to express through a brain that doesn't work well. So trying to help them to make that distinction, that you have a brain, but you're not a brain. But how you express yourself has to go through the filter of your brain. So don't get the two confused, so that you think, a brain that doesn't work well or works differently means that somehow you are less than.
Right. And Dr. Durr, we're actually going to bring it back to that point in a couple of seconds here, because that's one of the topics that we're going to discuss. But I'm going to go back to a statement that Dr. Berkeley mentioned earlier about her being from the Caribbean and how she did not have the mistrust of the healthcare system because the providers look like her. So I'm going to form this question to Dr. Bell. With your position as a residency trainer, what are we doing, or what is the healthcare community doing to get more providers of color, primarily more mental health providers of color? Dr. Bell?
Well, there's a problem of the pipeline, getting kids interested in medicine and getting people in medicine interested in going into psychiatry. There's a stigma against psychiatrists. A lot of people believe that not real doctors. Psychiatrists aren't real doctors, and you have to be, say, an internist or something like that to be a real doctor. So there's this stigma from that. And from the other end, there's all of our residents, people in training, are taught to spend lots of time with their patients. So as has been mentioned, we need to help the patients to understand that there's, as was said, that their illness is not them, and they can get better, and sometimes it doesn't require medication, which is often a big misunderstanding. So those are kind of the things that we have to work on, the pipeline, getting people into medicine, and from the other side, getting people to understand that psychiatry should not be threatening. And then there's the racial issue of my doctor's Black, is he worthwhile? That has not been too much of a problem for me since medical school. I had some issues with people in medical school, but really none since then. So there's this stigma coming from all different directions. The racial stigma, the stigma against psychiatry, and the stigma against mental illness, and they all make it difficult to get care.
So with that being said, is there anything being done proactively? I know we have to get the pipeline, but is there a proactive approach to getting young students, because like I have kids that are in school and we hear daily about the STEM program, the science, technology, engineering, and math. Is there something being formulated, or would being a physician fall under that STEM program?
The best thing that we can do that we've done here is we've had outreach. We've had health fairs where we go out into the community and we try to explain who we are and what we do. And if somebody needs an appointment, we set up resources for them and whatnot. So the idea is to have outreach and exposure so that we don't seem as dangerous or strange as some might make us out to be. So yeah, that's the big thing. There are some formal ways. I've seen people hand out cards with pictures of doctors and so forth in high school, so people can study history and know what people have done, especially Black folk, what Black folk have done in medicine. But it's kind of hard to do that with psychiatry because there are not a whole lot of us. So the pipeline and outreach like health fairs are the best way that we can educate the community. Of course, going to churches and schools, and that's another way of doing outreach. So those are the things that I'm familiar with that have worked.
And for the, you mentioned something about the ratio for the three practicing, for you guys that are in clinical practice, are you noticing that your ratio of patients is predominantly Black, mixed, predominantly white? What is that racial makeup?
Depends on where you are. Up here at University of Tennessee, I'd say that maybe 2/3 of our patients are white. When I was doing community psychiatry, the majority of them were Black. In private practice, it was about half and half. So it really depends on where you are. When we had a sliding scale clinic up here, there are many, many more Black folk up here because Memphis is majority Black. Right. But since TennCare, Medicaid, and whatnot, that kind of decimated that program, it's made it harder for people to come up to our clinic, and they have to be seen in community psychiatry. And there's not many resources for that. As far as Black psychiatrists, I could count them in this area on one hand. I don't think that would be an exaggeration at all. So for us to do outreach means for me to do outreach and for a couple other people that I know to do outreach. And, we do the best we can, but there are just not that many of us. I really mean there's not that many of us. A couple of thousand compared to well over 48,000 white psychiatrists.
Wow. Dr. Berkeley and Dr. Durr, would you say the ratio is about the same kind of general makeup?
I agree with Dr. Iverson in the sense of it really does depend on what location that you're working in. I did telepsychiatry for 8 years here in the state of Illinois, and because of that, many of the rural people that were actually part of our patient population were Caucasian. Where I am now, there's actually a good mixture of African American, Hispanic, and white patients because it's a fairly qualified health center. So it's a multi-specialty, practice, and so we feed into each other in terms of referring patients. But it really does. It depends. And to Dr. Bell's point. I'm a board certified child and adolescent psychiatrist. There are about 7,000 of those here in the US. Most of them are in the cities. So when you take 7,000 and divide it by 50, that's not too many per state, right? And then most of them are clustered in the cities, and then you start talking about African Americans. So, my understanding, there may be about 2% or so that are African American psychiatrists. I don't know the breakout of the child and adolescent psychiatrists in terms of African American, but either way, you're talking about a tiny, tiny fraction.
Right. Okay. Dr. Berkeley, do you have anything to add to this?
I agree with what Dr. Bell and Dr. Durr have said. I think that what also is key that Dr. Bell has mentioned is that when we talk about community mental health clinics, then that is where we will really see the Black population in terms of patients, which is a part of what contributes to disparities is the lack of insurance, lower unemployment rates. These are the things that lead the African American community to be overrepresented in the community clinics.
So it's interesting. I'm reading the chat as we're having this discussion, and one of the people in the chat basically says, I'm in Louisiana. One of my patients mentioned recently that she has never seen an African-American practitioner. So I'm assuming that's an African-American practitioner of any kind, whether it be internal medicine, OBGYN, psychiatry. Y'all got to get out there and get some work. Y'all have some work to do to recruit some more people.
Right. No, you're right. And, the question that you asked earlier about increasing recruitment within medical fields or within psychiatry, to be honest, I don't think that the majority organizations and medical schools see that as a problem.
Right.
So
I'm sorry, Dr. Berkeley, go ahead.
So it's I don't think that there's any plan to address it.
Right, right.
So I think really the foundational issue with that is because medicine is practiced in a very compartmentalized way. When I stop and think about it, and I thought to myself, I said, the truth of the matter is, even in terms of mental health, we don't talk about mental health as mental health is made up of brain structure and brain function and the thoughts you think. So you have to pick the proper solution for whatever the issue is. And so in allopathic medicine, of course, is what we have here in the US, and the way that it was developed, which was from an economic standpoint, it was to make sure that capitalists had healthy workers. So the focus is not on mental, but to me, it's astonishing, because if you think about it, everything that we experience except simple reflexes is coming through our brain. If you brain dead, you're done.
Yeah.
And you might, that's the reality of it. You might be on life support, but you cannot continue a sustained life without that. So at some point, they're going to stop the machines, and the person is going to transition on. So the fact that there's that basic fundamental lack of understanding that pretty much everything is coming through the brain, and that everything it's all connected, so that what I think, right, especially if it's over and over again, or if I'm really stressed, I'm going to be releasing those chemicals. Those chemicals are going to be affecting my structure, brain structure, right? And then I'm going to do things that's going to affect brain structure. So behavior and thought is changing brain structure, and then brain structure is affecting thought and behavior. So to have that basic fundamental lack of understanding and promotion of education, I think that's as a profession where we have severely dropped the ball. Because if we taught that to people, your brain is central command.
Yeah, it's a control center.
Right, it's central command. So if it's not working properly, then your life is not going to work properly. So I think and then you also, of course, have that as psychiatrists, we don't do a whole lot of procedures. Well, guess what? The folks that want to make money, a lot of them are driven to be in procedure-oriented specialties. So I think it's a combination of those things. Because, I'm sitting and talking to you, or, I'm prescribing medication, or in my case, I use a holistic approach. So I'm talking about nutrition, and I'm explaining to them, I said, it's two things that are required to build a quality product. It doesn't matter what the product is. And that's quality raw materials and quality workmanship. So if you don't give your brain the things that it needs, and again, in the factory to build healthy structures, it's not going to work properly. Junk food equals junk mood. So those are the kind of basic things that we don't teach, and we don't have to be a psychiatrist to teach that to patients about the critical importance of brain health. And I think we really need to start talking about it in that fashion, that it's brain health.
Absolutely, yes, and I agree. I do with my patients. I discuss mental health as brain health, because I think it helps them grasp the understanding that it's not about the mind, it's not about some intangible thing that's out there, it's about your brain. Just like your heart is an organ, your liver is an organ, what we address is your brain, which is an organ in your body.
And Dr. Berkeley, one of the things in talking to each of the panelists, whether it be Dr. Bell, Dr. Berkeley, Dr. Durr, Dr. Mollison, religion has come up at some point in everybody's thing, everybody's conversation. Growing up in the church, oh, Jay has depression, we're going to pray it away. Jay has diabetes, we're going to pray it away. That's prevalent in the Black community.
Yeah.
Dr. Berkeley, how do you overcome that if you're coming from a patient from a very strong religious household that says, you know what, I'm just going to lift it up to God and let him take care of it? How do you convince that patient that maybe they might need to swallow a pill after they lift it up?
Yeah, and so again, we get back to education and leading people to understand brain health, right? So the key is to, one, acknowledge that for someone who is religious, religion is important. So that's key, number one. We are not going to dismiss that, because that is key. It's where to get their support. It's very important. But the two are not separate. You don't have to make a choice between relying on your religion and relying on your doctor. Just as you don't make that choice when you go to the doctor for concerns about high blood pressure or cholesterol. Again, it's trying to get people to understand this is brain health. Like any other organ in your body. Things can go wrong with your other organs, things can go wrong with your brain. So just as you don't necessarily, you don't pray away diabetes, you don't pray away hypertension. I try to encourage people to understand that mental health is in that same category, and you want to go see a professional to help them along with your religion, to help you get better.
Well, Dr. Bell, you've been in this business for about 30 plus years. Have we made any progress? I mean, you've seen, you've seen a lot of things in your 30 years in practice. Have we made progress? Do you think there's a lot more that we need to do? What do you think?
Well, I'm tempted to think of, I think it's called the Texas two-step, with 2 steps forward and 1 step back. The more progress we make, the more resistance that we seem to run into. And January 6th was a good example of that. People do not like change. So yes, we've made some progress with the population in psychiatry. Yes, we've made some progress in racial relations, but people don't recognize that they have issues. and people don't like to change. So getting across the idea that somebody has, for instance, there's a systemic racism, people don't like to think of that. All they want to think about is the majority population is that, I never had any slaves, so it's not my problem. Racism is my problem. I'm not a racist. We need to educate, somehow find ways to educate people to be more culturally sensitive. We try to teach our residents to have cultural humility. In other words, to understand that you don't know everything you need to know about that other culture. You need to ask, you need to work with people, you need to talk to people and have them understand. One thing I did want to mention is in community psychiatry and a lot of clinics, we're given 15 minutes to talk to our patients, which is a lot of prescription time and not much talking time. That's also an impediment. So how are we going to educate people on psychiatry and the general population about racism if we don't get out there, if we're not doing outreach, if we're not exposing people to all these different things?
Wow. Very good. Thank you. With us being GeneSight Cares, we are a genomics company. So one of the questions that I have for Dr. Mollison is, because it gets back to genetics, clinical trials, and things of that nature, what have you done to encourage Black people to participate in medical research? And have you seen anything that works? Because just coming from my background in the pharmaceutical industry, we know that most clinical trials are void of Blacks across the spectrum of disease states. So what have you done to encourage Black people to participate in medical research, and what works?
So I had an opportunity to move from the wet lab into doing focus group studies with African-American parents from the lower socioeconomic spectrum, just to see their thoughts on integrating genomics into routine childcare. I think some of the things that work to get recruitment and to get the numbers up for that study was to go to where the patients are, to remove the barrier of having them to travel to UNC Chapel Hill. We had a rural site as well as an urban site. So on the weekends, I would go to Northampton County in North Carolina, bring food and non-alcoholic drinks, and have a friendly discussion. So I think identifying and removing barriers so that people can participate. I do think mistrust is an issue, but I really think a larger issue is access. And so if we want people to be able to participate, we have to remove those barriers. And even when I was recruiting participants, there were things I didn't think of. One of the places was in Raleigh, North Carolina, which is more urban. And someone said, well, are you giving away a bus pass? Is this focus group going to be by a bus stop? It's things like that that help to remove barriers if you want to engage those lower income communities and marginalized communities in research. At UNC Chapel Hill, we also had the chance to do a panel discussion at a Black Communities Conference for Collaboration. And we asked this question, what can we do to build trust? The first and most common answer was representation matters. People want to see leaders of research who reflect their community. So as Dr. Bell mentioned, that pipeline to developing research scientists, PhD scientists, and MDs is so important, but the pipeline is not the only thing. You have to make sure that it's flowing into actual positions. And there was an article that showed that the rate of delivering PhDs to minorities has gone up like 900 times, but the rate of hiring them has maybe increased 2%. It's really, astounding. But so that's one thing, the pipeline, but actually making sure that transitions into true leadership positions. I think next is to show up to these communities without asking for anything. That was another thing. Sometimes we only go to those minority communities when we need them to be involved in a clinical study. And then when we do that, a lot of times they never know the result of that study. So showing up without asking for anything, and if you do engage those communities, thinking of unique ways to disseminate the information back to those communities. We published in peer-reviewed journals. Most people do not read peer-reviewed journals. So how can you get the message back to the community?
Okay, very good. And you've chosen, Dr. Mollison, you've chosen to specialize in the field of pharmacogenomics. Is it viewed differently than any other areas of medicine? And go over just a brief definition for everybody else. What is pharmacogenomics and how is that viewed differently than the other areas of medicine?
So pharmacogenomics refers to how a person's genes will impact how they respond to medications. And of course, it's looking at your genetic code, your genetic variation. As humans, we are 99.9% identical. So that 0.1% creates all this beautiful variety that we see in the world, but sometimes that variety falls into a gene that may impact how you respond to a medication or may make you more susceptible to a disease. What I have seen, many people view their DNA and their genomics as sacred, that it is part of their destiny and that interfering or trying to intervene and sequence DNA can be seen as trying to play God. And so I think, there are reasons why people might be hesitant, but also even with those views, when people understand that getting a test for yourself that lets you know whether you're at risk for a cancer or whether you won't respond to a medication, you learn about yourself, but you can also learn about your family members. And it can be life-saving for you. It could also inform your family members as well. People are more receptive to that. So I truly think mistrust can coexist with the willingness to participate.
Okay.
I'd like to add something to that.
Yes, please.
If I could. I was part of the Pfizer COVID study. And when I tell people that, they say, oh, well, maybe I'll get the vaccine then. So it's getting people involved, companies making the effort to get the whole community involved. That's very helpful. And when I say the whole community, that means the minorities as well as the majority, and older people as well as younger people. So, and then let people, I guess, like me, go out there and say that, I was part of the study. I'm still walking and talking. I haven't turned anything strange. That's convinced, maybe not a lot of people, maybe just 2 or 3, but that's 2 or 3 more than would have been convinced otherwise.
It's interesting.
I just want to say there's also a push towards community-based participatory research where there's shared decision-making in the research process. So moving from this paternalistic view, we tell you the research that needs to be done, to a more shared discussion on what research should be done for these communities.
And if I could also add, I'm sure you
Yes.
need to move on to another topic, but
go ahead.
So I was just thinking, sometimes I feel like in medicine, the question we are asking lately is how do we get the Black community involved, whether it's get them into the doctor's office, get them in for genetic testing or research or whatever. But I feel like that is putting the cart before the horse. And I think before we ask about how can we involve the Black community, we have to ensure that the medical community is not going to abuse the Black community. And I think that needs to be the first question. If we ask it the other way, what we're doing is we're asking, how do we bamboozle the Black community into, the offices or into research? No, that is not what we want to do. What we want to do is to ensure that, first of all, medicine is going to treat these people correctly. And that ultimately is what is going to increase the numbers in the doctor's offices, in the research laboratories. And that's really what we need to do initially.
Very good. So I just wanted to point out 2 things. One, we're getting a lot of questions coming in through the chat. We're going to do our best to get to them near the end. And if we don't get to them, we will respond back. We have your information now. We have your genetic code. So we know how to get in touch with you. So we will be back in touch with that. One of the questions that was kind of really interesting that I just received was, what is the best way to bring up the need to have this discussion in the clinic, not with the patients, but with the staff as a whole? Because many of us go to clinics and work in offices where the provider may be a person of color, but the staff may not be. And these are conversations that aren't readily had. How do we explain the need for these conversations moving forward? Dr. Durr, you unmuted first, so I'll go to you.
I was gonna say you really went into the muck on that one. it's you know, one of the things, one of my sayings is that no relationship can be more functional or healthy than the most dysfunctional or unhealthy person in the relationship. So, and the importance of that is that when you as a provider or me as a provider are trying to provide care at a level that the staff does not understand nor appreciate, therefore they don't get the value of it, and therefore they don't participate in you know, the development and promotion of it in a way that supports the best health for the patient. So again, we're back to the issue of, you know, of education. We're also and frankly, the evolvement of healthcare in the U.S., where nurses are removed from the strategic position that they hold as part of the healthcare team to a reliance on medical assistance in the outpatient setting, I think is really creates challenges to deliver that quality of care, because you know, a nurse has a certain kind of critical thinking skills. They have a certain kind of you know, technical skill. They have a certain way that they've been trained to work with providers. And you know, one of my favorite persons in the whole wide world is a nurse. You know, Dr. Faye Gary, who's at the Case Western, and she helped shepherd me through my residency at the University of Florida. She was there at that time, but now has moved on, and she was, you know, wonderful and amazing. And so if you're a provider and you got any sense, you listen to your nurses, right? If they say, "You sure you want to do that?" That means don't do it.
Right, right.
You know,
Stop and think.
if they say, have you considered doing this? That means you should do that. So I think in terms of the other issue that we're looking at too is one of how financially focused our medical system has become because of capitalism, which is a disservice, you know, to the service to the patients. You know, again, nurses have to have a license to practice just like I have to have a license to practice. So it's another thing that concerns me. So I tell people I love nurses.
So one thing I might add.
Dr. Berkeley,
Yes,
I'm just going to add something in, and this is for brownie points. My favorite person is a nurse too. My wife of 23 years is a nurse. I hope she's listening. So
that's good.
I'm just getting brownie points in. If
that bought you some brownie points, yes.
And if she says don't do that, guess what? I don't do it. So
right. She's a nurse and a wife, so you're well taken care of. But what I was going to say to that individual's question, it sounds like she is operating in a clinic where she recognizes that there may be perhaps some disparities and is not sure how to raise that, as she is not the clinic manager, it sounds like, and she's not the decision maker. So what I would say to him or her is that education goes in more than one direction. So we want to, as providers, we want to educate patients, but also we need education as well. So sometimes we are not aware that we are doing things, or that the practice is operating in a way that may be not best suited for our patients. So I would say if there's a way that you could bring that topic up to the provider or to the clinic manager and educate them that perhaps these things are needed, cultural competency or whatever it is that you are seeing, the conversation that you're talking about that needs to happen in the clinic. If you can somehow try to educate them about its need, then hopefully you can manage to get that conversation going.
But I was gonna say also in that context though, I think it's important, you know, Dr. Bell made a comment and I was over here silently go, teach Dr. Bell, teach. Which is when he said that a lot of people don't want to change. And a lot of people frankly think they're right. They don't allow for the fact, you know, that they don't know everything. And they don't kind of think and process about the fact that what is it that I'm doing that's, is it working for me? Is it not working for me? And if what I'm doing, I'm repeating it over and over again, and it's not working for me, then I need to make some changes, right? And so that aspect has to be there, regardless of whether we're talking about patients or we're talking about staff or we're talking about providers or we're talking about, you know, the nurses. You have to be open and receptive to learn something new.
And exactly, when part of my opening was that change is uncomfortable. You know, it's never really a comfortable time to change. So, but we just have to keep pushing along. So one of the things that came up when Dr. Mollison was talking was just the whole genetic code and just the mistrust and stigmas and all of that. So one of the things is we go over and say privacy and protection are relevant concerns. I get this question all the time is, if I take a genetic test, can the information I share later be used against me? Is that a legitimate concern? And how can healthcare providers play a part in protecting their patients? So I'll push that one to Dr. Berkeley. Just is it a legitimate concern to be afraid of what's going to happen with your personal information with genetic testing?
Now, I have never looked into genetic testing, and I have never read their legal documents. What I do know that I've heard in the lay media, and so I'm not speaking as an expert in this, is that, you know, a lot of us have probably heard that there was some criminal activity that was actually solved by someone, a relative of the individual, having taken a genetic test. So it seems to me that they probably are ways in which that your genetic material may be used in ways other than what is outright said. But chances are it's in the document somewhere, the legal document. I would think it has to say that. I'm not sure where in the document it might say that or what sort of things you might have to look out for to know that it's going to be used in other ways. I don't know if Dr. Mollison has any recommendations on that.
And someone just put GINA into the chat. So GINA is the Genetic Information Non-Discrimination Act, which went into law, I think in 2008 under the Bush administration. And it prevents discrimination for having a genetic predisposition for disease in employment and in insurance coverage. It doesn't cover life insurance though. So that's one thing that is in place. And then there's also an IRB, Institutional Review Board. So any research that's done, whether it's an industry or government, has to go through, a review process to make sure that human rights are protected. And if anything is going to be done with the genetic information, that would have to be made clear to the participant.
But let's be real in the sense of acknowledging that some people misuse other people. And, you know, I had raised this in the conversation. So I'm going to say that even when, and we know, we've seen the stories on the news when people are taking people's tissue samples and using them in appropriate ways that the person never agreed to. We know that one of the other things that's come up, and it may not be as much of an issue with from a testing in terms of the medical community, but I think there's something that people should be informed, of course, is in terms of identity theft from a place of genetics, right? So one of the things that they talk about is the fact that when you do genetic testing with some of the companies in order to determine who you're related to, who your ancestors are, and what are some of your genetic predispositions in terms of illness, when it's blinded then, but when you seek to find relatives, it becomes unblinded. And when it becomes unblinded, then the person is predisposed to having their genetic material, i.e. their genetic identity stolen. So I think that's important. And I know we're kind of talking about different aspects of it, but I think that it is important to give people as much knowledge as possible, things they hadn't considered or thought about, and to understand that, let me just be clear. A contract is a piece of paper that two people agree to certain things. It doesn't mean anything unless both parties honor the terms of the agreement. Otherwise, it's just a piece of paper with signatures on it.
Very good. So this, just in the respect of time, I'm going to ask you one more question. We're going to do it kind of like a firing line with the four of you. So get ready, give me your best answer. But there's a phrase that we hear all the time, and it goes between multi-races and all that is, I don't see color. Does that phrase apply here? And I guess the question would be, do we need to see color? Now, here's the deal. I'm going to cut everybody off after 2 minutes. You get 2 minutes each to go through it. So get your best high school debate skills ready. And who wants to go first?
Yeah, Jay, I want to go first because one of the things that I wanted to talk about was the tag team on something that Dr. Mollison said, which was simply this. One of the things while we talk about things in terms of what happened from the Tuskegee experiment going forward, I call it experiment, not a study, is the fact that we really need to look at this even in terms of medicine and Black folks' mistrust of the healthcare system from a place of economics. What do I mean by that? Meaning that our ancestors were forcibly brought over here against their will, forcibly bred, so that they went from hundreds of thousands into 4 million people. The laws were changed so that usually you had the status of your father, but here you have the status of your mother. Why? Because it's all about taking a person, a human being, and turning them into a commodity. So color is important. I don't want people to think color is not important, but I think what we really miss is that the most important color is green. So really what's happening is we're squabbling with each other over resources. And it becomes, what do I need to do and who do I have to do it to in order to protect me and mine? There's a tribal mentality. So because we as people of color are easy to identify, they're easy for us to say, you're not part of my tribe, you're not part of me. So I don't want you to have access to healthcare. I don't want you to have access to housing and therefore better education. I don't want you to have access to quality food and to safety and the other things. And again, it's taking us and dehumanizing us as human beings and turning us into commodity in order to build capital, in order to develop or earn profit and power. And that's what the real issue is. So me as a person of color, it absolutely matters. But we need to understand that, again, to me, the real color issue is the color of green. And then I use color to discriminate, to say, you can't have access to these jobs, this education, this housing, this food, this whatever. So that's why you got all these PhDs with all this education, but no jobs and no position, because again, the color is used to keep them out. So who I am, as I started to say earlier, and I use spirituality and religion to work with my patients. I use it as a tool. And frankly, so who I am is an amazing being created by the creator of the universe. I'm the same as anybody else, right? I got a mind, I got a heart, I got, bones, and I got blood, I got muscles and sinew. So I'm the same as anybody else, a human being that wants happiness and fulfillment. But the reality is my color informs my perspective. My color influences my experiences with the society at large, even from the standpoint of saying, we a minority in this country, but not globally. Globally, people of color are dominant, but we buy into it. We buy into the stuff that says who are most of the poor, talking about, stereotyping, which is basically, is image control, right? Is who you ask the average person, who are most of the poor people? Black and white, in my experience, they usually say Black people. Right. And my point is, how is it that somebody, when white folks are 76% of the population, it's numerically impossible to be most of for Black folks who are 13%, maybe 14%, to be most of the poor. So they got everybody drinking the Kool-Aid so that the folks who don't have, the white folks that are poor and don't have and that are struggling, are fighting over the other folks down here who don't have. And it becomes, why is it that 4 people in this country have twice as much wealth as the lower 50%? What is wrong with us, right? Why are we buying into that? So my color matters, but it's not me. And so you have to take that into consideration about, again, perspective and experience, but don't try to define me or limit me and my wonderfulness because I happen to be a light-skinned goddess. With when I tell people, and these freckles here, those didn't come from Africa. that came from this light skin, and these freckles came from my Irish and European ancestors. So it's a part of who I am, but I'm not gonna allow you to use it to define or limit me. So okay. we need to understand that. We just need to understand that we're fighting over resources. So they trying to keep it, so we can't get it. When you understand,
Dr. Durr, listen, first off, I'm glad you're not my personal trainer, because that would have been the longest 2-minute plank I have ever done in my life. Sorry. So there was a really good question that came in though, and sorry, I know you guys got your 2-minute spiel together, but the question was, how does it go? Is the reason that some Black families, let me make sure I'm reading it correctly here. Do you think the reason why there are some Black families who do not talk about their personal family illnesses, especially terminal illnesses, is because of the distrust of the medical field, or are there other reasons behind that? Dr. Bell mentioned that, I think it was Dr. Bell that mentioned like his grandmother didn't tell him anything, or it might not have been somebody was saying that they didn't tell them anything. So is it because of a distrust of the medical field, or were there other reasons behind that?
With her, I'm fairly positive that there are other reasons behind that. But I think Dr. Durr said it very well, and she has several of my minutes because I agree with what she's saying. One cannot, the statement that I don't see color ignores, again, the term cultural humility. You have to be aware that different people have different values of things. Some cultures value psychiatry, some people don't. Some cultures don't. And some people value medical care, some cultures don't. So cultural humility says that you don't know everything about other people, you have to ask. Unfortunately, a lot of people just assume that they know Black people, or they know Native Americans, or they know Asians, and don't realize, for instance, that there are South Asians, there are North Asians, there are Southern Chinese, there are Northern Chinese. There are a lot of differences that people assume that don't exist. So including the economic part, we have to be aware that all people, obviously we aren't all alike. We share DNA, but we share some cultural differences I mean, there are cultural differences that we have to take into consideration as well.
Dr. Berkeley or Dr. Mollison, do you have anything to add before I close this up?
I will add 2 sentences. I relinquish the majority of my 2 minutes to Dr. Bell and Dr. Durr because they have said so much and they've said it so well. But the one thing that I think of when I hear somebody say they don't see color, I see that as someone who is uncomfortable with race.
Right.
Mm-hmm.
Very good. Dr. Mollison?
I would just add that my hope is that all people have access to cutting edge technology and precision medicine to better health outcomes. I think because of the situation of our history that we have to see color in order to see equitable access. Some communities need more help than other communities, and that has to be acknowledged in order to make sure that there is fair access.
Very good. So the last question, and nobody's going to answer. This is a question that everybody's going to kind of go home and think about tonight. It just came up on the chat, and I'm glad that it didn't come earlier because we would not have gotten past this question. The question is, how can a white person who acknowledges the privilege of being white better interact and build trust with Black and Brown patients and colleagues? And given the historical issues you've presented, does that typically happen quickly or does it take time? Time?
Oh, absolutely.
Time and interactions. I'm sorry.
Yeah, you unfortunately, you cannot rush that because everyone is bringing their history of experiences into any interaction. It's a dynamic. So thank you so much for being someone who is concerned about the world. We so appreciate that. Unfortunately, some of the people that you interact with would have had negative experiences with people who look like you, and as a way to protect themselves, they may build walls. So you have to just consistently prove that you are someone who is interested in their well-being and in the well-being of others. But not only that, what you can also do is make sure that all your friends and your family, all others that you see. In New York, there's a statement after 9/11, I believe it said, if you see something, say something. So what we have to do is address the larger issue of racism. You yourself wanting to reach out and do better is great. You are only going to start seeing strides when others who look like you are also doing the same.
Very good. Well, guys, that's kind of our time. So I'd like to first start out by saying, Dr. Bell, Dr. Berkeley, Dr. Durr, Dr. Mollison, I've been honored to be able to share the Zoom screen with you. When we see each other in person, we're going to get a nice hug. We'll all have our vaccinations and all that. But thank you guys very much for your time. So again, I'd like to thank this wonderful panel, not only for their time, but their professionalism and willingness to share. If you have any further questions for the panel or for me, please share that on chat before you leave. And stay tuned. We plan on continuing to ask the hard questions with GeneSight Cares in hopes to move the needle. Thanks again for allowing us into your homes this evening, and have a wonderful night. Thank you.
Thank you.
Night, everybody.
Good night.
Bye-bye.